Hi everyone, this is Ryan, Mega, and Ellie, and we are presenting on the neurological disease of epilepsy. Key behavioral symptoms of epilepsy is characterized by seizures caused by abnormal brain activity. Epileptic seizures are a result of the rewiring of brain circuitry and the birth of new brain cells, neurons, and glia. Severe epileptic seizures can cause brain damage and abnormal brain development. Seizure signs and symptoms may include temporary confusion, uncontrollable jerking movements of the arms and legs, loss of consciousness or awareness, psychiatric symptoms such as fear or anxiety. Some focal seizures impair people's awareness to not be able to perform repetitive movements like hand rubbing, chewing, swallowing, or walking in circles. Other focal seizures without loss of consciousness cause emotions to alter and for senses like vision, smell, feel, taste, or sound to be impaired. Involuntary twitching of an arm or leg and spontaneous sensory symptoms such as tingling, dizziness, and flashing lights are sensory symptoms that may occur. Between 30 to 50% of children with epilepsy develop a behavioral health problem, according to the Massachusetts General Hospital for Children. These types of behavioral problems associated with epilepsy include attention deficit, hyperactivity, anxiety, depression, aggression, and autism spectrum disorder. Many people who have epilepsy experience dysphoric episodes lasting between a few hours and a few days. These episodes consist of depressive moods, irritability, lack of energy, pain, anxiety, insomnia, and euphoric moods. Children oftentimes have significant behavioral problems and emotional difficulties causing them to act out. Changes in emotional state is prominent among behavioral features in epilepsy. Psychosis, depression, paranoia, impotence, anxiety, panic attacks, and other dysfunctional behavior are behavioral features characteristic in epilepsy.
So the causes of epilepsy are very broad. There's a lot of different causes, but basically we've narrowed them down to four main categories. So the first one is idiopathic, and this has a predominantly genetic origin. So if you see in the top figure here, there was one study where they were looking at a specific type of epilepsy, and they could narrow it down to just one nucleotide substitution, which is the F there. These idiopathic kinds of epilepsy usually are not associated with any neuroanatomic abnormalities. So if you're doing brain scans, you don't really see any major differences between healthy controls. So some examples of this category are benign familial neonatal convulsions, severe myoclonic epilepsy of childhood, and then autosomal dominant nocturnal frontal lobe epilepsy. The next kind of epilepsy is symptomatic, which this also has genetic origins, but it can be like just acquired throughout the lifetime due to brain injury or things like that. And the difference between idiopathic and symptomatic is that this symptomatic version is very much associated with gross brain abnormalities. So if you're doing scans, you're going to see very big differences between these patients and healthy controls. So a couple examples are West syndrome, Lennox-Gastaut syndrome, and hippocampal sclerosis. So you can go to the next slide. This is just one example of like the abnormalities you would see in brain structure, but in the top A and B slides, you can see there's on the right side, this is the participant with epilepsy. There's pretty severe atrophy of the CA1, CA2, CA3. And then in the bottom row, you can see that compared to the healthy control, there's really no definition of the different areas of the brain. So like on the left, you can see there's a pretty big difference between the GCL and the IML, whereas on the right, you just don't really see that at all. So these are the kind of things you would see in the symptomatic type of epilepsy. The third category is provoked. So these are specific environmental factors causing the seizures. And again, we're not really seeing any neuroanatomic abnormalities in this one. So this is going to include reflex epilepsy. So I feel like the most common one we've heard of is like who will have seizures to flashing lights. So that would be an example of a reflex epilepsy. But these are caused by things like really, really high fevers. If you have like 104-degree fever, maybe super high or low blood sugar levels. A big one is like withdrawal from alcohol. So if alcoholics all of a sudden stop drinking alcohol for 24 hours or something like that, that could cause seizures. And then general gist is like cerebral trauma, whether that's infection, tumors, TBIs, things like that. Um, well, if it was TBI, in that case, you're seeing pretty prominent abnormalities in the brain, but otherwise you're not. And then the last category is just cryptogenic, where the causes are very much unidentified. And this is usually adult onset epilepsy. So most of the childhood ones, we know more what's going on, but not so much for the adults. And this is going to account for a pretty big portion of epilepsies. It's 40%. So there's still a lot of research we need.
So this is the effects of the disease on the brain structure. Sometimes severe seizures can cause brain damage, but most epileptic seizures do not have a detrimental effect on the brain. Epileptic seizures cause brain injury because prolonged seizures, they can kill brain cells, and they cause other damage too. Seizures contribute to nerve cell injury in the brain. So in this study that you can see on this slide, conducted by Garcia Ramos, so the study compared participants with childhood epilepsy to healthy controls. So you can take a look on the differences in the brain structure between A and B. What was found was that there's higher thickness and purification in superior parietal lobe. Specifically, epilepsy groups showed lower volume in the right thalamus. There's lower thickness in the precentral gyri bilaterally, and there was also a profound volume reduction in the ipsilateral hippocampus. These patterns of changes were measured across different epilepsy syndromes. There was an overall reduction in gray matter, which indicates that epilepsy syndromes involve widespread compromise of structure.
So the effects of epilepsy on memory. So memory can be significantly impacted in individuals who have epilepsy. There's a few main areas of concern, and we'll talk about attention and encoding first. So attention is a prominent area where people will notice reduced attentional speed and a reduced rate at which information is processed. There's also an issue with sustaining attention, and people will notice a reduction in their attention span. And these impairments with attention will ultimately lead to a reduction in the ability to encode information. So this leads to individuals being distractible and overwhelmed with information. And since individuals are not able to process information as effectively, they will miss out on critical information. So this involves either people not getting all their information because they can't process it at the speed it's given, or because they're not able to stay focused. And missing out on background information or seemingly irrelevant information can really affect people's quality of life because they won't be able to follow events as effectively. Now for effects on storage, a lot of people will have what they call an effect where they will hear something in one ear and then out the other. So that reflects that there is a deficit in storage. And specifically, this deficit comes up in not being able to consolidate information as effectively. In terms of issues with retrieval, people will have issues with accessing information. There is the role of interference. So for example, remembering one thing can affect people's ability to recall a target memory. There is also troubles with generating context for retrieval. So context is a very important part in recalling a memory. And if individuals with epilepsy are not able to generate that context, it impairs their ability to retrieve the memory. And lastly, this mainly affects declarative memories. So that's episodic memories for events that are experienced, and semantic memories for knowledge, concepts, and facts about the world.
So we looked at the study by Alabone, and this looked at 102 adult participants. So half of them had epilepsy and the other half are healthy controls. And in this particular study, they were looking at mesial temporal lobe epilepsy. There's a lot of different versions, so you're going to see different effects, but this is definitely a more common one. So we're looking in this study at autobiographical memory. The way they tested this was through the AMT. So they were looking at participants' reaction to positive and negative connotated words. So like if they were given the word happy, they were asked to recall a memory. So there were 3 different kinds of memories that could be recalled. First one was specific. So these are memories that could be localized to one day. So like an example would be like, oh, I was sad when I lost my high school soccer game, like the last one or something like that. An extended memory is something that lasts for more than one day. So this would be more general, like, oh, I was sad when I was in high school. So that's lasting multiple years. And then the last one is categoric. And these are describing repeated events. So it could be like, I feel happy when I dance. You dance repeatedly. So that would be a categoric memory. Then they went a little further than that and they looked at self-identity. So they used the EIPQ, Ego Identity Process Questionnaire, and they're looking at the participants' beliefs across 4 ideological domains and then 4 interpersonal domains. So ideological domains include things like religion and politics, and the interpersonal ones are more like family beliefs and values. So from that, the EIPQ, they are putting people in 4 categories, which you can see in the photo here on the left side, either foreclosed, diffused, achieved, or moratorium. And I'll talk a little bit more about those later in the study, but you can go to the next slide. So the results from this study, which you can kind of see here on the left, showed that participants with epilepsy have a significantly decreased autobiographical memory, which is to be as expected. The way they measured this was that participants were recalling significantly more categorical memories. So remember, these are ones that describe a repeated event. And they were recalling a lot less specific memories, which are ones that occur in one day. So it's kind of indicating that they can't really retrieve very specific memories. They more have general autobiographical memories stored. And like at one point when I was reading the article, they were saying like the patient was given the word surprise and he answered, I went to New Zealand and got to see my first cousin. So you can kind of see like there's not really a surprise factor there. There's definitely something going on. And in the graph here, you can see the recall of specific memories is 4.5 for patients with epilepsy compared to 7.26, which is much higher for controls. And you see those same differences in each one that are reflecting that they don't really have these specific memories they can retrieve. So based on that, the experimenters kind of took, okay, what's happening with these autobiographical memories and correlated it to self-identity. And they found that because epilepsy patients aren't really able to form strong autobiographical memories, they really have, it's affected their self-identity. So a lot of them are showing diffused and foreclosed self-identity. So they don't really have a clear sense of self or commitment to any ideals in a diffusion identity, or in foreclosure, they're really just kind of going along with the beliefs of their family and friends rather than exploring identities for themselves. So the time of onset is definitely going to affect what we see in autobiographical memory and therefore self-identity. So the earlier the time of onset, obviously, the worse effects you're going to see later in life. And this is kind of the graph showing here. You can see the MT patients are the dark diamonds, and it's all kind of clustered on the left and foreclosed and diffused. Whereas with the control and the normal patients, they're more spread out through the middle.
So for the second study that we chose, it basically explores any links between the age of epilepsy onset and the extent of memory impairment. So this is a bit similar to the first study where it's looking at the effect of the age of when epilepsy was onset. So basically the study took 92 patients with focal epilepsy who had similar cognitive and psychiatric functioning compared to controls, and they underwent evaluation for three things, for autobiographical memory, overall memory function, and they did a mood assessment. So the autobiographical memory testing was done through an autobiographical memory interview, which is a semi-structured interview assessing personal memories from childhood, early adulthood, and recent life. And they received a score which indicated if their impairment can be classified as amnestic syndrome. For the overall memory function, that was tested using the Walshler Memory Scale, which assessed auditory and verbal memory. And the mood assessment was done using a structured clinical interview to diagnose any mood disturbances according to the DSM. The results of the study showed that patients with epilepsy performed worse on semantic and episodic memory tasks. They also had reduced episodic memory and reduced working memory, and that was associated with people who had earlier onset epilepsy. And overall, there was a higher rate of depressive disorders in individuals who had epilepsy. And in patients that had late onset epilepsy, there is a link between depression and being able to recall autobiographical information. And this study basically suggested the benefits of subtyping patients earlier so that they can predict cognitive dysfunction as a way to enhance people's quality of life. And this figure at the bottom basically shows the determinants of poor autobiographical memory and how they vary by the age of onset. So people with early onset epilepsy have impaired autobiographical memory, which is linked to the seizures being chronic and having reduced working memory. And then people with late onset epilepsy are shown to have an impairment that is largely predicted by the symptoms of depression. And these are our references.
Awesome. I feel like that